So without further ado, I will introduce our first speaker, which is Dr. Kim Nylund. He is from Bergen, and he is affiliated with the National Center of Ultrasound and Gastroenterology in Norway. He is a consultant at Haukeland University Hospital, and he is also associated professor at the Department of Clinical Medicine at the University of Bergen. He is also, for the time being, postdoc doing research on advanced applications in GI ultrasound, and it's a great pleasure for me now to give him the word to talk about basic methodology of GUs and normal findings. Please, Kim.
Thank you. I'm going to start the presentation. So I would like to thank EFSUMB for the opportunity to present in this webinar. My talk is titled Basic Methodology of Gastrointestinal Ultrasound and Normal Findings. So this lecture is, of course, the secret to understanding all the following lectures. This is an overview of the talk. I would briefly like to mention the development of the guidelines on which I based my talk, and then I will guide you through the different tips and tricks that are needed to perform a good examination. There you go. This is the image of the first page on the guidelines. In 2017, there was an EFSUMB task force group that started with examination techniques and normal findings. 19 recommendations were made, some of which I will mention specifically in the talk. And in the paper, the recommendations are presented with levels of evidence, grade of recommendation, and also level of consensus. Because you have to realize that for many of the investigated subjects, little or no scientific documentation exists, which means that your main guide will be the level of consensus. So this is a table presenting the levels of evidence as shown by the Oxford Center for Evidence-Based Medicine. And here is the grading of the evidence, which is based on the size and number of supportive studies. Hence, we also included grading of evidence in the recommendations. But since normally the effect of different ultrasound parameters have been infrequently studied, the level of evidence is low, grade 4 to 5. Hence, we included the level of consensus in the recommendations. So to the equipment. Starting, you need a general curvilinear abdominal probe in combination with a mid to high frequency probe. Now, what exactly is a high to mid frequency probe? Opinions tend to differ, but in particular in the case of gastrointestinal ultrasound, we consider probes with ranges starting at 5 megahertz and up as this category. Why? Because such probes provide the axial resolution needed to separate GI wall layers and the GI wall from adjacent structures. Should we go as high as possible? Well, no, because mid-range transducers are a good compromise between sufficient axial resolution and depth penetration. So here's an example of the difference between a curvilinear probe and high frequency or mid-range frequency probe. And you can see that the left image, you can barely see the GI wall, while in the right image, you have a very clear image of the GI wall and the layers. So what does harmonic imaging has to do with the image quality? Well, again, on the left side, you see an image without harmonics, on the right with harmonics. And what harmonics does is reduce noise, as you can see, but the cost is reduced depth penetration. I do keep it on as default, however. And finally, what does the curved versus the virtual convex has to say for the quality? Well, purists would say maybe you have a better resolution with the linear probe, but the curved gives you a better overview. Over to another modality, pulse wave Doppler. Here I'm just mentioning, because this is what we treat in the guidelines, measuring the superior mesenteric artery. You should keep 2 to 3 centimeters away from the origin. The trick is to angle the probe correctly to get a good Doppler angle. And what about color Doppler or power Doppler? In most machines, the available color Doppler is more than sufficient, and you can detect vessels inside the GI wall. Typically, you could keep your wall filter and velocity scale low, and the patients need to hold his or her breath to avoid motion artifacts. And the gain also has to be optimized to avoid flash artifacts. I turn the gain up till I get flash artifacts, and then I turn it down again till they disappear. And here you see just two normal recordings. You see a little bit of flash in both of them, while here in the Crohn's recording, you see clearly the vessels inside the bowel wall. What about contrast-enhanced ultrasound? We know that we often need to inject higher doses of the contrast when using high-frequency probes. But is it useful? Well, it's definitely useful for separating avascular from vascular tissue. Several studies also show that it can be used to assess the perfusion of the GI wall, either by simply categorizing different levels or by quantifying it. It can, however, be tricky to analyze, but I'm sure that Kala Sara will talk more about this later. Above, you can see the perfusion in the GI wall in the Crohn's patients, and below an avascular area and also in the Crohn's patients. So perhaps elastography has a room in the measurements in abdominal ultrasound. Well, it can be used in selected cases, as this one, for instance, but obviously this is ex vivo. How will it perform in the clinical setting? There are some recent studies that indicate that it may have some use, but I think a lot more work is needed in this case. Again, that froze a bit. I'm showing you this recommendation specifically as it was a broad consensus in the task force group that all people that are training for bowel ultrasound should start after you have trained in abdominal ultrasound. Then to the beauty of ultrasound. In what other modality is no preparation needed to examine the GI tract? Of course, since we are doing a full ultrasound before doing the abdominal, the GI wall ultrasound, the patient is usually fasting. And sometimes installing fluids can improve visualization, but in general, you can stand a patient unprepared at the first visit, and also at the third, and at the second and third and the fourth, because it doesn't harm the patient. But I guess you already know that. So to the scanning. Since you finished your abdominal examination, you're already holding the curvilinear probe in your hand. You start the scanning by looking at the rectum, both in sagittal and longitudinal direction. And you see the rectum lying behind the vagina or behind the bladder and prostate. It's definitely tricky to discern the healthy rectal wall, and in this region, pathology is most frequently missed. So to scanning of the colon. You start in the right iliac fossa and you follow the colon downstream from the cecum. The ascending and descending colon are easily seen in both flanks, while the transverse colon can be difficult sometimes to find because it crosses in several different levels. But if you miss it, you might go to the left flank, left flexure, and then backtrack. This proximal sigmoid is easily seen crossing the psoas muscle, while the distal part can be difficult to see, especially if the bladder is empty. Then for the small bowel, again, you return to the right fossa and then you scan the terminal ileum, and then you move up and down like a lawnmower while compressing the abdomen, making sure that you can see the dorsal part of the abdominal cavity. Then you know that you haven't missed anything. Again, it's difficult to see in the pelvic region if the bladder is not full. So then to how you look at the bowel wall and measure the bowel wall thickness. it can be very thin, down to 1 millimeter or less, as seen here in the image. And if you blow up the image, you see how the different wall layers are shown. You have one with of the terminal ileum and one of the colon. And the calipers you place here in the interface between the serosa and the muscle, and between the mucosa and the lumen. We measured the abdominal wall thickness in 122 healthy subjects and found that for the most part it was below 2 millimeters, except for in the antrum, the duodenum, and in the rectum. So a consensus in the group was that the normal bowel wall thickness is less than 2 millimeters, but this should not be considered the cutoff for pathology. I've been talking a lot about layers. There are 5 layers seen in the abdominal wall, or in the gastrointestinal tract. First, the interface between the muscular proper muscle and the serosa, then the rest of the proper muscle, the submucosa, the mucosa, and then the interface between the mucosa and the lumen. When you measure the abdominal wall thickness, you should put your calipers exactly at the interface between the serosa and the proper muscle, and then down to the interface between the mucosa and the lumen. And you should keep it perpendicular to the wall and avoid contractions and hostrations. Then you have how you measure what is normal when measuring the superior mesenteric artery. Again, I show you the measurements and an example of peak systolic velocity and the resistive index in this case. And in the literature, there's a wide variety of values you find. There's a variety between for instance, the resistive index between 0.8 and 0.89. And again, a very wide variety between the peak systolic velocity between 80 and 220 centimeters per second. So this means that it's quite difficult to separate pathology and normal values. Now to how it looks. How does it look, the bowel, when you look at it? This is a nice scan going through the terminal ileum to the cecum, and then or through the ileocecal valve and to the cecum. And very often we make images like that, but obviously it varies. So how does it look in the duodenum? I find this is a difficult part to examine, and usually I just get good images of the bulb. But sometimes if you add fluids, you can see a little bit further down into the duodenum. In the small bowel, you typically see this air floating up towards the probe, and you can have nice motility going up to 8 to 10 contractions per minute. The Duodenum is located in the umbilical region, while the ileum in the hypogastric and pelvic region. Obviously, the peristalsis will vary in fasting patients, because sometimes it will be in phase 1 and sometimes in phase 3 with a lot of contractions. So how does it look? Furthermore, you can see the folds in the mucosa. That can be much clearer in the Duodenum, also called the valvula conniventes. The lumen, when you look at it, it can be this grayish fluid, or more like water, like shown in these images. In the colon, you typically see the hostrations, and then the muscles go into the hostra when compared to the folds in the mucosa, where you don't have the muscle going into it. There's rarely any motility, and you see the air is mixed with the content. You see it caught little air bubbles inside the fecal content. Here's typically a pathological bowel shown down in the right corner. In the appendix, it's always attached to the cecum, obviously, but it can have variable direction inside the abdomen. But you can often find it between the terminal ileum and the cecum. It should be below 6 millimeters, and it should be compressible like this one here. And then we rarely talk about the lumen in the bowel, but as I mentioned previously, typically in the colon you can see solid content, or you can see fluid content, like in this patient here with diarrhea. And also in the small bowel, you have the chyme, which is grayish and fluid. And sometimes, or very often with pathology, you find a little bit of water-like content, which is more like black. And then when you finished your examination, you have to do a report. And I always think it's important to mention the areas you did not see, and then you mention the areas where you find pathology. And when you do that, you mentioned how thick the wall was, the extent of the disease, how it affects the GI wall layers, how it affects motility, any changes in the lumen, and obviously extraintestinal changes. Yeah, that's our last recommendation. And then for summary, you should use the curved abdominal and the linear probe, B mode harmonic imaging, and color Doppler has also a use in looking at the bowel. You don't really need to prepare before the examination. You should have a systematic approach to how you scan the bowel. Bowel wall thickness has been shown again and again to be the most important parameter. And you should report your report should be focused on the findings and also on the exam quality. Thank you for your attention.
So, thank you very much, Kim Nylund, for this very interesting introduction into basic scanning and into different methods of how we can do the scanning. To all the attendants, please let me remind you that you can write your questions in the right margin of the GoToMeeting software program, and we will try to forward the questions to the speaker. So please take that opportunity if you like. But let me first address one question for you, Kim. As we talked about in the beginning, ultrasound of the GI tract is fairly advanced and should primarily been taught after you had some basic training in other types of abdominal scanning like liver, pancreas, and so forth. Have you any specific tips and tricks for the beginners? How should they start the training in GI ultrasound?
Well, I would obviously train where I do look at the whole abdomen, looking at all the organs first, and you should have a certain amount of examinations, like for instance at least 300, I think, maybe abdominal ultrasounds, regular abdominal ultrasounds, before focusing too much of the bowel, because then you will only be frustrated in the beginning, I think. But also I think it's a good value to know how to examine the bowel, because it helps you to improve the visualization of other organs, because your knowledge of where the bowel is and what it covers and how it works, it really helps you to look at other organs in the abdomen too. So it's really a strength to learn how to do that.
Yeah, and there is one question from the audience here. How many GIUs are needed to be performed for one to be considered competent? Do you have any ideas of that, Dr. Nylund?
I guess you have the 3 rule in your EFSUMB guidelines. So you should look at 3 and then perform 30 under direct guidance, and then 300 under access to guidance, and then 3,000 you're an expert. I don't really know. I don't really know if I've done 3,000 yet. So
that's a good way of putting it. Yes. And I think also regarding if you have one organ system like the GI tract, you may become an expert long before 3,000, but that's a fairly good overall estimate. We have another question. Is there any specific landmarks that you can explain to identify specific areas?
Yes, you use, I guess, both external and internal landmarks. The external landmarks are very useful when the anatomy is normal, because then you just put your probe where you expect the specific bowel to be. For instance, you could put it in the right fossa, and then you look internally to find where the vessels are crossing the psoas muscle. And if you're keeping it below or going down, then you will be outside the abdominal cavity almost. And then you could flip the probe upwards, and the first thing you see is very often the terminal ileum. Sometimes the cecum will cross there, and then you don't see it that well. On the other fossa, you will see the same thing for the sigmoid. So these are good landmarks. And also the flexures, if you go intercostally, well, you see the kidney, and on the right, kidney and liver on the right side, and you see the kidney and stomach on the left side, you very often find the flexures in this region. So it's a good place to start looking. Again, the flanks, go all the way out to the flank on both sides, and you will find the descending and ascending colon.
Okay, thank you very much, Dr. Nylund. Because of the time, we have to move on to our next presentation.